Welcome in, everyone. Thank you for joining us today. So, just to be mindful of the time, I will go ahead and get started because we have a lot of information to cover today, and I want to make sure that our panelists are presenting all of their details about PH-ILD to you today. So again, welcome to this PHA Live webinar hosted by the Pulmonary Hypertension Association. Today's webinar will be broadcast in both English and in Spanish. And at this time, we would need you to select your preferred language. I will ask that we advance the slides to the language screen so we can share exactly how to choose your language of choice if you have not done so already. So you can either select English or in Spanish, and at the bottom of your screen, you should see a globe that says interpretation. You can hit that globe and then select either English or Spanish. It is very important that you mute original audio or you will hear both. You will hear not only the speaker, but then also any interpretation that is provided. So again, at the bottom of your screen, you should see a globe. And then once you click on that globe, you will see the option to listen in English or Spanish. Once you do so, you can select your language of choice, and then you should hear either myself or an interpreter or a panelist. So if you selected English and our panelist is speaking in Spanish, you may hear the interpreter. And vice versa, if you selected Spanish and our panelist is speaking in English, you may hear the interpreter. So I'll give everyone a moment to select their language of choice. Are you able to advance that, Crystal? Yes. And if you click one more time to go to the interpretation screen. So here are those instructions again for selecting your language of choice. Again, globe, interpretation, listen in English or in Spanish, and then mute original audio. All right, so now we will go ahead and get started. A few programming notes. We will have the opportunity for Q&A immediately following Dr. Bernardo's presentation. Our Q&A will be moderated by our panelist, Dr. Singh. You may submit questions throughout the webinar by using the Q&A button at the bottom of your screen on the toolbar. Please remember that our panelists cannot answer any personal and specific medical questions. Those questions should be directed to your healthcare team. We also ask that you complete our survey to let us know which content you would like to see in the future. At this time, I would like to take a moment to thank our sponsors for their support of this webinar. Our sponsors such as Johnson & Johnson, Merck, and Gossamer have supported this presentation for you today. We would like to also note that sponsors do not participate in the development of and do not endorse program content. We also will hope that you would consider becoming a member of PHA. Our professional members can gain access to online medical education, apply for research grants, and enjoy discounts on event registrations. Our memberships are also available for patients, and patient membership is free. Also, PHA has launched a career center for those interested in jobs in the pulmonary hypertension field. Those jobs are available for your review. Visit jobs.phassociation.org to find your next opportunity. And now I would like to recognize our supporter and partner who will speak here today from the Foundation Against Pulmonary Hypertension in Spain. I would like to invite their executive director, Enrique Carazo, to start our programming. So Enrique, take it away.
Todos. Good morning, everyone. My name is Enrique Carazo. I'm not only the president of a foundation against pulmonary hypertension in Spain, but I'm also Daniel's father, who is affected by this disease. On behalf of the host of the PHA, it's an honor to welcome you all to this webinar from different parts of the world. Our mission today is to increase awareness, to have more educational resources, and provide hope to families and patients affected by PH. Furthermore, we want to promote research and participate in innovative projects worldwide. Today's webinar reflects this global commitment that we share. PH and ILD-PH is a complex disease that requires collaboration beyond borders, connecting clinicians, researchers, and patient communities. We are strengthening, therefore, collective knowledge that fosters better treatments and results in the long term. Our webinar today is Advancing ILD-PH, a global innovation, gathers experts from around the world that will help us understand the current situation and where research and science is leading us to. This is an essential dialogue because we're working on early detection of the disease, better treatments, and better support for patients. We also want to thank the Fibrosis Foundation to make this webinar possible. Our organizations are joined by a common vision that is accelerating significant research and someday find a cure for pulmonary hypertension and associated diseases. We're also proud that this webinar is in English and Spanish, streamed in both languages. This ensures that more researchers, families, and clinicians can have access to information and common perspectives today. We have three specialized leaders, the cardiologist Bernardo, Alejandro Cruz Utrilla, Roberto Bernardo, and Navneet Singh. Their knowledge and expertise will guide us through the latest developments in research in terms of pulmonary hypertension and ILD. Once again, thank you again for being part of this global community. Your participation helps to boost knowledge on the current situation, and this makes us closer to improving the lives of those suffering ILD-PH. Thank you very much to all of you participants, attendees, and sponsors to this webinar. Now, without further ado, I'd like to give the floor to Dr. Singh, who will be also a moderator in this webinar today.
Thank you so much for that introduction, and thank you to the organizers for inviting me to speak today. I'll be discussing the current state of interstitial lung disease, pulmonary hypertension, or ILD-PH. I'm an assistant professor of medicine and pulmonologist at Brown University in the United States. Next slide. Next slide. So we'll start off with just a few definitions. So first of all, of course, we're all here to talk about pulmonary hypertension, which, as many of you know, is caused by increased resistance of the pulmonary vasculature and is defined by an elevation in the pulmonary artery pressure greater than or equal to 20 millimeters of mercury. And we diagnose this by right heart catheterization, which is done as a mandatory procedure to diagnose the condition. Next slide. We're also here to talk today about interstitial lung disease, which is a collection of many diseases that eventually causes progressive scarring of the lungs and many different patterns. What you're seeing here is a CAT scan of an example of a type of ILD called idiopathic pulmonary fibrosis, or IPF. And so you can see at the red arrows, scarring of the lungs at the borders, predominantly at the bases. And this is a classic radiographic pattern of scarring that we see in IPF. Next slide. Next. So ILD can happen for a lot of different reasons. And so this is a summary that I like to show. It sort of shows you the breadth of the different sorts of things that can contribute to progressive fibrosis in the lungs. And they can all be sort of categorized underneath what sometimes is called diffuse parenchymal lung disease. What we know mostly about ILD PH comes from idiopathic pulmonary fibrosis, which you can see all the way on the left-hand side, really is just one piece of the entire picture. And so one thing to highlight today is that although we do know quite a bit about ILD-PH, there are many forms of the disease that remain less studied. And so there's a lot more to learn. And it's important to understand that a lot of what we do know now and the way we practice is correlating what we've learned from IPF and translating that to other lung diseases. Next slide. So why does ILD happen, and how does it potentially contribute to pulmonary hypertension and problems with the pulmonary vasculature? On the left here is a diagram of a healthy lung, and you can see here the airways, the bronchioles, and the alveolus, and how they interact with the blood vessels in the bottom left. And in between the airway and the blood vessel is an area called the interstitium, which is where oxygen and carbon dioxide gets exchanged. On the right-hand side, you can see a diagram of a diseased IPF lung, and you can see that around the airways are many fibrocytes and fibrosis that is laid down, extra collagen deposition, and this is what causes that scarring that we see on the CAT scans. When we sort of zoom down into what's happening, we call this interstitial fibrosis because the predominant area where we see this happening is in that region between the airway and the blood vessel. And so among other things that are happening, one of the things that we know is that it's interfering with gas exchange, interfering with oxygen uptake. And so some of the predominant symptoms that we see in people who have ILD and PH are both low oxygen levels or hypoxia and shortness of breath. And this is part of the reason why that happens. Next slide. Here it is in a real human tissue. So on the left-hand side, you can see a comparison of a single person's lung who has IPF. And so at the top right of this panel A, you can see an area with lots of fibrosis, the pink tissue here. On the bottom left is more healthy appearing lung with the open airways with air able to exchange. And you can see in the center, you can see a blood vessel that's quite thickened and branching out into an area of normal lung. And you can see how those airways thicken in those same areas where there is that interstitial fibrosis, showing that there is the relationship between abnormalities in the blood vessels in the same areas where we see abnormalities in the actual lung tissue itself. On the right side, we see similar changes happening, specifically staining of the pink here for smooth muscle cells. So a different part of the blood vessels, different thing being highlighted here. And you can see here that we see the smooth muscles cells being enlarged. And it's not only in the airways where we'd expect them in folks with pulmonary hypertension, but also in the interstitium as well, suggesting that there are similar parallel processes happening both in the vasculature and in the parenchyma of these patients. Next slide. And so how common is it that PH develops in people with interstitial lung disease or ILD? Well, what we know is that typically this happens most commonly in those with fibrotic lung diseases or lung diseases related to scarring as opposed to inflammatory lung diseases. And the challenge is that, again, the data on prevalence are limited. So we know that about 8 to 15% of patients with IPF will have an elevated mean PA pressure during their initial workup, but it will change depending on the etiology. And so for those with NSIP, that prevalence is maybe slightly higher, 31%, and even higher in those with chronic hypersensitivity pneumonitis. And so if you think back to that image I showed you before, you can see how many different subtypes of ILDs or diffuse parenchymal lung diseases they are. And you can imagine how the prevalence really varies from subtype to subtype. And so it can be challenging to know exactly the individual prevalence for each specific subtype. Most of what we talk about or we translate out to other diseases comes from our knowledge in IPF. Next slide. When we talk about ILD-PH, again, we talked about fibrotic interstitial lung disease. And typically what we see is they actually tend to have mild or to moderate pH at most. Severe pH is what we think potentially a completely different subtype and happens from different pathobiological reasons. The predominant phenotype in this disease is more moderate disease. And this comes from cohort studies. For example, this one here from several years ago, looking at IPF patients listed for lung transplant. 20% had mild pH, 30% with moderate, and only 10% had severe pH with a mean pH pressure greater than 35. And the rest, which was 40%, had no pH. What are some of the more poor prognostic factors in ILD-PH? Well, so of course, although it's not as common, higher mean pH pressures are thought to be more of a poor prognostic factor. And of course, higher resistance, so PVR greater than 5. And it's thought that PVR greater than 8 may discriminate survival even more. Low cardiac index, not surprisingly. Low DLCO, which will speak to the amount of fibrosis specifically and impairment in gas exchange, and also with abnormalities in the vasculature. On the echo, estimates of pulmonary artery pressure and dysfunction of the right ventricle, and then more precisely, but it's done less commonly, is measures of RV strain on cardiac MRI. Next slide. So let's talk about some more specific subphenotypes of ILD-PH. So one of the more common types that we talk about is connective tissue disease ILD and PH. Within CTD-ILD, this is not just one homogeneous group of people. There's many different diseases that can contribute to this. And so because of this, as we get to fewer and fewer subgroups of people, the prevalence data become more and more limited. So some of the diseases that we talk about commonly are systemic sclerosis, mixed connective tissue disease, and rheumatoid arthritis. In systemic sclerosis ILD-PH, the prevalence remains poorly characterized. It's thought to be somewhere between 6 and 31%, which is a really large range, and this really requires much more study. Survival data also are quite discrepant. So in one particular meta-analysis from 2013, survival data was 35% compared to 56% for those with and without ILD. However, in a Spanish registry, it looked like the survival comparing the same two groups was 35 versus 43%. And so more work is needed to understand the prevalence and survival in this particular subpopulation. We think that mixed connective tissue disease and lupus-associated ILD behave differently, but they have even less specific data. And part of this is because some CTD ILDs may respond better to certain therapy than other fibrotic types of ILDs, and that complicates the factor even more. Next slide. Another really important subtype that's becoming more understood and more prominently diagnosed in the last several years is combined pulmonary fibrosis and emphysema, or CPFE. And this is a condition where folks who have emphysema are found to also have fibrosis, oftentimes in the bases, and have this sort of combined phenotype. What we're learning is that the pH occurs more commonly in this subphenotype of fibrotic lung diseases than in some other types. Upwards of 30 to 50% of folks with this type of ILD will develop pulmonary hypertension. And when they do develop pulmonary hypertension, it tends to be more severe and with a worse prognosis. These folks often are more symptomatic and have higher oxygen requirements, both at rest and have marked impairments on CPET. So for this reason, the accurate diagnosis and early diagnosis of CPFE is critical so that we can capture these people, screen them for pH, and potentially treat them. Next slide. Now, going back to IPF-PH, which is again where the bulk of these data really come from, we know that 20% of all cases of ILD are IPF. It's the most common type, and that IPF is more prevalent in men and males as opposed to females, and there's an increased risk in those who smoke. It's important to know that even echocardiographic pH, or small elevations in pH greater than 17 millimeters of mercury, is associated with reduced survival in IPF. And so it's important to capture this early, even if it seems that it might be mild early on. What's really interesting is that the degree of the parenchymal involvement, or the degree of parenchymal fibrosis, doesn't seem to correlate with the pH severity. So I showed you many pictures where fibrosis histologically correlates with vascular abnormalities. It seems that clinically there seems to be other factors driving pulmonary vascular disease independent of the fibrosis itself. Next slide. but it still matters. And so what we know is that survival is affected regardless of severity. And so this is a study that combines both COPD and ILD patients. And it looks at different severities of PH, borderline, mild, and severe. And what you can see in the survival graph on the right is that the folks who have no PH, which is that top blue line, separate very clearly to all the other patients, even though they're separated out by the degree of their pulmonary hypertension. And all those other patients together have a much lower survival compared to those who have no PH. And so this is important to capture because, again, irrespective of the mild or severe nature of the pulmonary hypertension, these patients warrant close attention and potentially treatment. Next slide. So let's talk quickly about screening and management. I think a major question is whether or not patients with ILD-PH should be treated. These are not the same phenotype of patients as pulmonary arterial hypertension patients, group 1 disease patients, and oftentimes the decision is much more nuanced and individualized. Next slide. So who should you screen? This is a really nice set of patterns of signs and symptoms and other clinical metrics that we received courtesy of a colleague, Sarah Kahn from Johns Hopkins. So first, here are some signs and symptoms that might prompt a screening in a patient with ILD or PH. So folks who have obviously shortness of breath, functional limitations, any chest pain or pressure, weight gain, which might be a sign of edema, and then red flag symptoms like syncope or pre-syncope are extremely important to capture and well characterized. Next. We can look at physiologic data to help support suspicion, lower or raise our suspicion. So pulmonary function testing, so someone with a DLCO less than 40% or a decrease of more than 15% of baseline. And then we can also look at the DLCO FVC ratio. This is something that's been captured in many different risk scoring criteria that some of my colleagues will speak about in a few minutes. The 6-minute walk test is one of the most sensitive tests that we have to look at changes in time according to symptoms objectively. And we're looking specifically at decreased distance and desaturations. And of course, changes in chest CTs, including increased PA diameter and PA to aorta ratio. Next. Underlying disease is very important here to think about the epidemiology of the disease and the likelihood of the development of severe PH. So connective tissue diseases we talked about, we know that scleroderma is one of the more common CTDs that can lead to ILD-PH, and when it does happen, it can be more severe. But other diseases like sarcoidosis are important to remember. We talked about CPFE, that anyone who has CPFE identified and has dyspnea unexplained by their radiographic findings PH should be a consideration. Other organ dysfunction like heart disease and other comorbidities should be considered as well. Managing the disease is very challenging because these are two diseases that progress and often worsen over time, and it can often be difficult to understand which part of the disease is driving the clinical worsening. Is it the PH or the ILD? And there are many different tests that can help us differentiate the two, but ultimately these decisions and considerations should be done in an expert center. And that's where groups like the PHA and its counterparts in Spain and other parts of the world are really helpful at connecting patients and providers to expert centers so we can get these answers for our patients. Next. Next slide. So I won't go too far into detail, I'll leave that for my colleagues, but one major question that'll help start to frame is, should we use pulmonary vasodilators in ILD-PH? Many of these drugs have been studied in PAH and not group 3 PH or ILD specifically. And this framework from a paper from last year is really helpful because it helps show us certain domains and characteristics of the patients and patients' diseases that help us favor PH therapy or not, including things like comorbidities, hemodynamics, biological domains, so factors, morphologic domains on CT, and other considerations. Next. When we talk about adjunctive therapies, non-pharmacologic therapies, importantly, we consider things like supplemental oxygen, diuretics for volume overload, in physical activity, pulmonary rehab becoming more and more recognized as an important intervention in this group. And then, of course, comorbidities like obstructive sleep apnea and left-sided heart disease. Next. Why do these medications sometimes fail in ILD-PH? Well, Dr. Utrilla will tell you a little bit more about the data, but I'll tell you sort of broadly, some of this happens due to known physiology. Blood flow is shunted from areas where there is disease normally, where gas exchange is hindered, and that's a natural compensatory mechanism. And when we treat people with pulmonary vasodilators, we disrupt this natural biology and physiology, and that may lead to worsening hypoxemia and dyspnea. Next. And so lastly, I'll just mention briefly some factors about lung transplant listing. ILD and PH are both separately indications for referral and listing for a lung transplant. And you'll see here highlighted in the boxes in red are some of the reasons why you might list someone for transplant in ILD, specifically hospitalizations and declines, pneumothorax, or other exacerbations. And in PH, simply the existence of underlying ILD or CPFE with RV dysfunction can be a criteria for listing. And so these patients in whom there are candidates, transplant should be thought about early. Next. And here's that information again. Next slide. And so some of the discussion referral considerations, we have to remember that transplant may be the most viable treatment options for especially our most severe patients. And so these early discussions should start whenever you can. And this gives you time to address reversible obstacles. So things like social factors, support factors, financial barriers, and things like that, smoking cessation, treatment of concomitant comorbidities. And this is because the waiting time for an organ depends a lot on allocation center and patient-related factors. And these factors are different all around the world. And so taking time to consider these factors is important. And so referring these patients early is important. Next slide. And then lastly, I'll discuss just briefly when all these interventions don't meet the goals or as the disease progresses, it's important we incorporate palliative therapies when necessary. And remember that this is not always for those who are at the end of life, but simply for assisting with symptom management. So supporting folks with oxygen pharmacologic treatment for relief of dyspnea and other symptoms. And then hospice services, which vary around the region and the world, but are really helpful to support the treating clinicians with reassessing symptoms. And they often exist as an arm of palliative care services, depending on the system. Next slide. And that's all we have. I'll hand off to my colleague, Dr. Utrilla.
Thank you very much, Dr. Singh. And thank you, Enrique and PHA. I want to introduce myself. I'm Alejandro Cruz Utrilla. I'm a pulmonary hypertension unit and the Hospital Universitario 12 de Octubre, which is a reference center for pulmonary hypertension in Europe. Next slide, please. These are my disclosures. So next slide, please. When I was preparing this presentation, the first thing that came to my mind was that I think we are living a revolution, group 3 PH, especially in terms of treatment. Why? Because throughout the last 20 or 30 years, we have gone through relevant changes with enormous progress in group 1 PH, the PAH, but we hadn't had significant advances in group 3 PH, respiratory disease associated PH, which is what we are talking about today. However, I think this is a revolutionary moment when we ask ChatGPT what revolution means. This is what it tells us. It says this is a prolonged process in time where there are some dramatic changes that change the course of events drastically, and that oftentimes cannot be seen but after some time has passed. And these are the important historical revolutions. Nowadays, we're going through the digital revolution. In the case of group 3 PH, I hope we are witnesses a revolution in terms of treatment. Next slide, please. As it was explained, pH associated to respiratory diseases is more prevalent as compared to other rare pulmonary diseases like group 1 or group 4. But in most cases of ILD pH are mild. So the vascular disease is not predominant. So I want to say a note that in all of these groups, the prognostic factor is the right ventricle dysfunction. And if we don't do anything, the pH, if we don't treat pH, then there will be drastic heart failure. The mechanisms in which there is vascular damage lesion, the main factor is smoking. That will damage the vasculature in the lungs, but also in the lung alveoli and the interstitium. Next slide, please. One aspect in which there is important progress, in which we see revolution, has to do with diagnosing. We can diagnose more PH and severe PH cases. And we can see more changes because we can diagnose more cases because we are able to identify those factors that Dr. Singh was talking about that may be associated to ILD-PH. And what about diagnosis? Well, we have a clinical suspicion, lack of air, chest discomfort, edema, and we start with complementary investigations. But to detect if there is PH, I will need a right heart catheterization, which is an invasive procedure. And between these two clinical domains, if I have fatigue, if I faint, if I have edema, my respiratory test, my 6-minute walk test, my blood workup, etc., I'll have to go through an echo of the heart that will assess the probability of suffering PH or not. And especially in ILDs, then the echo is not enough. So we'll need a right heart catheterization. But we don't have a perfect test or a combination of tests that is perfect nowadays. So in this sense, there are lots of clinical trials ongoing. Many ongoing trials in different centers worldwide are trying to find a single scale or tools to determine or to identify pH in patients or in which patients I need right heart catheterization and to diagnose pH. We suspect that many patients have chronic lung diseases, especially in ILD, that do not have a diagnosed pH, but patients that already suffer pH. As I was saying, artificial intelligence can help us in this respect. It may, in the future, with scan data where we can see the scars, these may provide the data that may suggest pH. And in the future, hopefully, we may even avoid the right heart catheterization, but we are still far from this. This is the first revolution. The first revolution has to do with more diagnoses, not just because there's more suspicion, but because we are able to combine the basic simple tests, including the heart echocardiogram, that will have more right heart catheterizations and have more diagnosis of ILD-PH. But where we expect more changes, because nowadays we don't have important treatments that have worked out in ILD-PH, is in clinical treatments, in therapies. I'll tell you about the present and probably the future in this group of ILD-PH. I don't want you to have a look at all the data in this table, but this is a nice summary of many of the clinical trials, randomized clinical trials on ILD-PH only. I'd like to show you how some of the trials have not observed an improvement in terms of the endpoints, and some of the trials were even negative. That is, patients had a tendency to worsen as compared to those receiving placebo. And the one that had better results, that was the INCREASE randomized trial. It improved the primary endpoint, that is to improve the 6-minute walk test, but it also showed interesting results as to the heart function and pro-BNP data, etc., etc. Something similar can be observed in COPD-PH. Different drugs have been tested, and some clinical trials have shown that sildenafil, for example, sildenafil used in group 1 PH might have some benefits for patients, but inhaled treprostinil has failed in COPD PH. So with all the different drugs that we have for group 1 PH have been tested, almost everything has failed, but we haven't tried the new, so that the drug in group 3 PH. I hope that this may be tested in group 3 PH. We have been testing the different pathways that provide vasodilation in the small blood vessels in the lungs, but most of the results have been negative, as Dr. Singh was mentioning. In many cases, there were significant adverse events. I've talked about inhaled treprostinil, which is a known drug for group 1 PH. This is a prostacyclin that is a potent vasodilator that might have other effects in terms of cell proliferation or anti-fibrotic even. In the case of group 3 PH, it has been tested as an inhaled administration. It needs to be used several times a day, but this is the only one available commercially in the US, not in Europe yet. But this is the only drug that we have as a treatment for ILD-PH. So what do the practical guidelines tell us about what we do in our clinical practices? Well, they tell us that if my patients have ILD-PH that is severe, that has a right heart catheterization of over or greater than 5 units of wood, well, we need to consider inhaled treprostinil. If my patient has COPD or a CPFE or some specific diffuse interstitial diseases, then we might consider other treatments. But in those cases that are not hemodynamically compromised, we might be more cautious and try to participate in more randomized clinical trials. Next slide, please. And finally, let me tell you about some clinical trials in the pipeline, some concepts. Of course, I don't want you to read the whole of this table, but simply to show you that we are going through a revolution. Because maybe this form of PH is where there is more development, where the industry is investing more because of the bad prognosis of the disease and because of the need for having good drugs. One of these pathways is to use nitric oxide. We are investigating one new drug that is mostly what the concept is that this is a vasodilator of the small blood vessels in the lung. The concept is that this drug might have this vasodilation effect, but it might also have an anti-inflammatory effect and act on this cell proliferation and lung fibrosis, which is even more important than a loss of blood vessels in the lung. And some molecules that have been under research is seralutinib that acts on a different pathway that is known in other diseases, like in blood cancer, that might have a more anti-proliferating effect and anti-fibrotic effects that might act on different cells implicated in lung fibrosis and inflammation, especially at the level of the lung. So it might be interesting to try this drug out. This has been used in group 1 PH in a phase 2 trial, and we are looking forward to having the phase 3 trial results. In phase 2 trials, it showed to be effective and safe, so we will see what happens in phase 3 trials. And finally, these are not the only drugs. This is a new drug also acting on fibrosis, inflammation, and it's going to be tried out in group 1 and group 3 PH. So the next slide, please. I want to show you with all this information that there is a lot of research going on. Next slide, please.
But we mustn't forget that perhaps the most important part in this type of pulmonary hypertension is not vasodilation, but to treat fibrosis, to hinder fibrosis, to stop fibrosis. And pneumologists have been having a lot of hope regarding the new drugs. This is a new drug that has been published recently last September that proved that there are drugs that can slow the progression of the fibrosis. We knew some other drugs for the progressive anti-idiopathic pulmonary fibrosis, and this is a randomized, a new drug that has been added to the armamentarium for pulmonary fibrosis, to treat pulmonary fibrosis. Next slide. So to wrap up, I think that we have some hope because we will be having lots of drugs because there are tons of clinical trials studying these drugs, and there is greater enthusiasm nowadays. And now I would like to leave the floor for Dr. Roberto Bernardo.
Thank you, Alejandro. And thank you, PHA, for inviting me to be here tonight. Navneet and Alejandro, those were great presentations. My name is Roberto Bernardo. I'm a pulmonologist at Stanford University. When we talk about pulmonary hypertension and interstitial lung disease. Next slide, please. Those are my disclosures. And the next slide. When we are talking about PH and ILD, we are talking about two severe illnesses happen to a person at the same time. On the figure on the left, we have the echocardiogram of somebody with severe pulmonary hypertension. Alejandro, Navneet, and I, we know how to treat this. We have very effective medications to achieve what we want to achieve to improve the quality of life of a person suffering of PH. But when the parenchyma, when the lung of a person affected by ILD looks like this, there is severe parenchymal compromise, there is severe inflammation and fibrosis in the lung tissue. It's very challenging to treat that. The next slide. Pulmonary hypertension is usually described as a rare disease, but in reality it's not. Using global data, Marius Hooper and his colleagues describe that, let's talk about the figure on the top, that close to 50% of individuals that have PH related to left-sided heart disease. Another 30 to 40% of patients that have PH related to chronic lung disease. But the figure at the bottom, it refers to patients with pulmonary arterial hypertension. And the etiologies or the causes of PAH will differ depending on the region. In Europe and the US, idiopathic pulmonary hypertension will be the most common etiology in more than 50% of patients. And in certain areas like Brazil or Africa, schistosomiasis or congenital heart disease will be more prevalent. The next slide, please. PH is very prevalent. Some estimates assume that 1 out of 10 individuals older than 65 years have PH, and usually it's due to left-sided heart disease, what we call heart failure with preserved ejection fraction. The next slide. I really like this figure. It's from a paper by Peter Leary using data from the Global Burden of Diseases data set. They were using a global data set to estimate the morbidity and mortality of PH, meaning how severely how affected individuals are when they have PH. What I like about this figure is trying to show you areas of the world that have available data for analysis. There will be the areas on light blue or green, but on the areas that are light gray or close to white, those are parts of the world where we don't have such data, where we actually don't know how affected individuals are when it comes to symptomatology or survival on individuals affected by PH. As you can see, almost the entire African continent, we have a lack of data. And that doesn't mean the disease does not exist there. It just means they may not have the means to report what is actually happening over there, which is devastating. The next slide. On the same paper, they are trying to quantify the disability that patients have when they are affected by pulmonary arterial hypertension. When it comes to the years of life lost due to PH or the disability adjusted life years due to PAH has a more negative effect on disability on patients than testicular cancer, MS, or Crohn's disease. The disability related to PAH is similar to what we see in patients with leukemia. That can just give you an idea how, many on the audience know this because you live with this disease, how disabling can it be to have PH. The next slide, please. When we try to quantify the symptomatology of patients, meaning how affected patients are by PH, We have some data. We may not have a lot of data for PH-ILD, but we have data for other types of PH. When it comes to pulmonary hypertension due to left-sided heart failure, we know that daily life activities, just such as dressing or making the bed, sweeping, vacuuming, or doing grocery shopping, can require so much energy for patients that they feel exhausted after doing activities that you need to do for a daily life. It's not even exercising, it's just carrying your daily lifestyle. The next slide. And something similar has been estimated for PAH. Activities such as doing laundry, folding clothes, cooking or preparing the table for your meals, or just taking care of your yard can require so much energy for individuals, can be so limiting. And again, that's reflecting just how difficult daily life comes for patients that have a disease that, yes, there are treatments available, but still, even with therapy, even with the support of your caregivers, you are still affected by this disease. The next slide. So what I want you to know from what I told so far is that PH is highly prevalent. It is. And patients with PH have impaired quality of life, have a high symptom burden, and the data that we have so far is very limited. The next slide. Most of the data that we have is coming from registries or clinical trials, which is great. That's where data needs to come from. But the problem with registries and clinical trials is that minorities, such as Hispanic patients or people of color, are underrepresented in these registries and clinical trials. The next slide. Kushbugol, not so long ago, put together this figure to illustrate that. At the top, you have some of the more frequently cited registries in PAH, and at the bottom, you have some of the clinical trials up to 2021. In Lilac, you can see the predominant population in these registries and trials, which is a white population. As you can see, the representation of Hispanics or other minorities is pretty low. It's pretty low. So we're using data that is predominantly white to infer what will happen to other populations. The next slide. And then we also get to talk about the social determinants of health. These are the factors that individuals are born with and get to grow with and determine how or what access they have to care, education, and things like that. Social determinants of health relate to education, access, and quality, healthcare access and quality, the characteristics of your neighborhood, your social and community context, and of course, the economy of the family. The next slide. When we try to understand outcomes in PH, we relate to differences in sex and gender, genetics and the biology of the disease, socioeconomics, differences in exposure to environment and other exposures, the quality of access to healthcare, exposure that happens even before birth, and differences in lifestyle. And of course, it may also matter the color of your skin or your race and ethnicity. Next slide. And as we group all these factors, we know that other factors may matter as well, especially in the US. It may matter your immigration status, any barriers that you have with language, health, technology, literacy, mental health, any barriers that come with transportation. Gas is so expensive these days in the US, social support and use of illicit substances. All these factors combined may constitute barriers to optimal medical care, enrollment into clinical trials, adherence to therapy, and continuity of care. The next slide. And to top all of that, all of you already know, but PH care is expensive. on this figure, these investigators are trying to compare the cost that comes at a hospital system, that cost that comes for a patient that has PAH compared to someone that doesn't have PAH. And the inpatient cost can be 60 times higher. The cost for pharmacy for somebody with PAH can be 20 times higher. And the overall cost of somebody with PAH compared to someone that does not have PAH can be 90 times higher. That is not surprising to any of you, but PH care is very expensive, even if you have proper healthcare insurance. The next slide. So what I told you so far is that getting proper care in PH and getting access to care in PH is difficult and it is expensive. And to this date, despite the research that some of us do, our understanding of the significance of social determinants of health in PH is still very, very limited. The next slide, please. So there are many things that we still have to do. There are many gaps in knowledge and proposed next steps that some of my colleagues have proposed in the past. But certainly, we need to know more about PH outside the US and Europe. That's very important. There is more than we need to do to understand outcomes and symptom burden in minorities that have PH. We need to do more analysis for understanding of geographic and environmental exposures. Working together with patient associations such as PHA is important, is pivotal so that we can achieve these goals. The next slide. And that's all I have for you. And I think Navneet and everybody, we can answer some questions from the audience. Thank you for having me.
Thank you all so much. We have a couple of questions that we've been answering in the background. I think one question that I'll bring up, and maybe we can discuss this a little bit amongst ourselves, was regarding some novel efforts to modulate the neurohormonal axis in pulmonary hypertension. And so the question from the attendee was regarding a more novel approach using ultrasound to achieve neuromodulation, specifically in the spleen. And what I had sort of responded or started to respond was that this is part of, a larger body of work that's really mostly in pulmonary arterial hypertension, to my understanding, modulating the neurohormonal axis, and that it seems quite promising. I'm not sure aware of really a lot of research specifically in group 3 PH. I don't know that we know that the mechanisms of modulating the hormonal axes has been shown to be effective here. But I do think that it's a promising approach, and I think we'll probably see a lot more about it in the future. I don't know if Roberto or Alejandro, if you have thoughts as well.
I agree with you, Navneet. There is some promising early data. Hopefully that will, the success of these studies will maintain as larger studies are conducted, but some of the data I'm aware of is denervation of the pulmonary artery. Some of this data has been presented for both PAH and PH in the setting of heart failure with preserved ejection fraction. It's still too early to know what the real outcome will be from this, but I think it's exciting that this is being explored. I'm not aware of any data for PH-ILD though.
I have nothing else to say. This is a promising treatment. I have no experience and I'm not an expert on it.
I think one thing I'll add, and I also made this comment in the Q&A, was that I think this highlights how pulmonary hypertension is a systemic disease. And so ILD-PH is a great example. It's an interplay between what's happening in the lung parenchyma, the pulmonary vasculature, and then the actual heart itself. And so that is sort of a great sort of model for how we can think about pulmonary hypertension and treating sort of the whole body instead of just thinking about treating the pulmonary vasculature or the pulmonary fibrosis itself. And so the example that was sent to us was regarding modulating the spleen and how it might affect inflammatory cells in the pulmonary vasculature or around the pulmonary vasculature. And so I think that's very exciting. I think one question that was brought up was whether or not there are early trials we're aware of. I think specific to ILD-PH, I'm not aware of any. There are some early trials in PAH, although I think they're just limited to the United States, but they wouldn't necessarily be in ILD-PH. Another question that's come up is our experience in treating ILD-PH beyond inhaled treprostinil. And so I don't know if you guys maybe want to take that one to start. What's your experience in using non-prostacyclin therapies for ILD-PH in the real world?
We do it sometimes. When we treat PH-ILD, as both of you summarize on your lectures, we try to maximize the medical care as possible. Inhaled treprostinil is our go-to medication, but the PDE5 inhibitors, such as sildenafil, I think overall those are safe medications to use. A study using global data from the registry, from the PVRI Go Deep registry, all of you are familiar with it, showed that there may have been a outcome benefit on the use of PDE5 inhibitors in patients with PH-ILD, maybe even a survival benefit or so. Of course, this is observational data. We don't have any strong clinical trial data about PDE5s, but I think overall they seem to be very safe as well. But at the end of the day, I think what medications will be used or not is between the patient and the provider. They know all those details quite well. We just know at the data level what to say.
Hi, it's Angela. I don't think there are any other
I had a
questions.
similar perception. I think that many patients with PH, ILD, and PH are benefited from these drugs, as registries show. And I think that other patients are benefited from inhaled treprostinil. I think this is a safe treatment and it's backed up by clinical trials. Access in Spain is limited yet. We can only ask for it in selected patients. And experience with these patients show that there are different results, outcomes, because its use is reserved for patients with severe diseases. And I think that in these cases, we arrive late. We have to insist that the only curative treatment is lung transplantation. So if the patient is a candidate, we have to assess that possibility too.
Right, I agree with both of you. I think that highlights really just that how important it is to bring patients like this to expert centers. It's such a nuanced decision. And I think even the same patient, all three of us, we might have different ideas about the way to approach. It's really individualized to patient preference, what's realistically available in that center, that region, socioeconomic considerations for each individual and where they are. It's really can sometimes be really challenging and requires a lot of interdisciplinary discussion for each patient. I think my personal experience is that there often are a lot of options outside of prostacyclins, but again, it just takes a lot of discussion and sometimes a bit of careful trial and error to understand what's going to work best for each patient. Another question in the chat is from Christine Oldani. Are there any trends or data on the prevalence of ILD in PAH? I was diagnosed with PAH this year and being treated with tadalafil and macitentan. I'm in a low-risk PAH category now. I've had limited scleroderma for 15 years. I couldn't quote the data off the top of my head. Maybe my colleagues are more experts with the actual prevalence data. But I will say is that just because a patient with PAH has fibrosis on their CAT scan does not mean that they have predominantly ILD PH. And this is, again, where the phenotype gets to be a little bit more mixed often. And so it takes really careful consideration to understand what's the primary driver of the pulmonary vascular disease. Is it primarily in the pulmonary vasculature, so more of a PAH phenotype? Is it more of a pulmonary parenchymal phenotype, so more of an ILD-PH type of picture? The therapy would be very different. And there are some important ways that we can distinguish that. So typically, as you remember, we discussed, we expect ILD-PH to have mild hemodynamics. And so those with more severe hemodynamics, we would think might fall closer on a PAH spectrum as opposed to ILD-PH. Those with more impaired pulmonary function testing, DLCO, low FVC, typically would be more falling into an ILD-PH type of perspective. And so those are some of the factors that I think about when I'm seeing folks who have both features of PAH group 1 disease and ILD, and how to differentiate them. But it can be difficult. I don't know if others have thoughts.
Christine, I'm so glad to hear you have achieved a low risk status. Congratulations on that. That's so important. Congratulations to you and to your doctor. There is a study that was sponsored by the NIH and also by PHA called PVDomics, where they studied all forms of PH. And in this study, they found that patients with PAH may have some areas of inflammation in the lungs, what we call ground glass opacities. So it's not uncommon for patients that we believe have PAH to have some degree of inflammation in the lungs. Also, as Dr. Singh mentioned, it's not uncommon that somebody that we believe has PAH has some degree of interstitial lung disease as well. It takes a lot of expertise and collaboration among PH centers. Who do we label as PH-ILD and who do we label as more of a PAH phenotype or so? And that's important because treatment may vary depending on that. I believe the prevalence of this inflammation in the lungs or ground glass opacity is about 10% or 15% in patients with PAH. Another thing to keep in mind is sometimes patients with connective tissue disease, such as yourself, Christine, who have scleroderma, you may have not had interstitial lung disease at the beginning, but you may develop that after 5 or 10 years. So things can always change or so, but again, we are so glad to hear you've achieved a low risk status, which is what we aim to do when we treat patients like you.
Thank you. The next question is regarding a more connective tissue disease. So what do you know about lupus, ILD, PH, or PH due to lupus inflammation and vasculitis, vascular inflammation, overlapping with Sjogren's and APS as well as IgA deficiency? Yes, that's a lot, but maybe each has their own role in PH and ILD. Yes, I agree. I've been talking a lot, so I have a lot of thoughts about vasculitis and PH, but I'll let my colleagues start off and jump in if you'd like.
I can go first. It's a lot. It's a lot. SLE is an interesting type of connective tissue disease. Sometimes the PAH that comes with SLE can respond very well to immunosuppressants, and sometimes with very effective immunosuppressants, the PAH can be somewhat cured. The antiphospholipid syndrome, on the other hand, can make patients prone to develop blood clots, and that can also trigger a different phenotype of PH or a different type of PH called CTEPH or chronic thromboembolic pulmonary hypertension. That by itself sometimes may need surgery or procedures to decrease the clot burden, and that can be very effective to treat pulmonary hypertension as well. Those are my two guesses, I guess. Navneet, is there is a lot of overlap between connective tissue diseases or so, but SLE, on my experience at least, tends to improve with immune suppression. Not all the time, but many, many times.
Yeah, I agree with everything you said. All of those individually have different mechanisms to contribute to pulmonary vascular disease. I think one thing that I find really interesting is the data suggesting that flares of connective tissue disease like lupus can actually increase hemodynamic burden of the disease, suggesting that in certain subphenotypes of people, when there is a connective tissue disease inflammatory vascular component, that a vasculitis type picture actually relates quite directly to the pulmonary hemodynamics as well. And so I think that we don't fully understand that and how you might harness that to treat it, because it's true that just immunosuppressing someone with, for example, lupus doesn't treat their pulmonary hypertension completely. So there's more to it than just that, but there's definitely that component as well. And so that's why I'm not a rheumatologist, but I partner with rheumatologists to make sure that people with connective tissue diseases and ILD, PH, or a connective tissue disease, PAH, have appropriate immunosuppression if it's indicated, because it's an important component of it all. And so I think what you're highlighting in this question is how complex these diseases can be and how it requires multimodal treatment therapy. So when you hear it would be anticoagulation, immunosuppression, maybe pulmonary vasodilators, antifibrotics, all of those could potentially be beneficial in this type of picture.
Alejandro and Navneet, if I may, what are your thoughts about sotatercept? We know it's working very well for PAH, and we know activins are increased interstitial lung disease as well. What are your thoughts?
I think we have to explore more about this in cases of PHA associated to sclerodermia with diffuse interstitial disease have been treated with sotatercept. So in the future, I'm almost sure that and I'm sure we all have patients of this type, and I think that in the future, we need to keep on exploring this therapy. Pathophysiologically, this makes sense, but there are some data associated with sotatercept that are worrying. There are some saturation side effects that might be worrying in group 3 PH.
Yeah, I agree. I think it's not a straightforward picture. I think sotatercept obviously is exploding onto the market in many different types of pulmonary hypertension, but I think we have to be cautious not to overgeneralize an effective therapy in one subtype to all subtypes, because the mechanisms, as we talked about, are so different. And I think what distinguishes group 3 and ILD-PH from group 1 pulmonary arterial hypertension is that the mechanisms are maybe more heterogeneous even than in group 1 disease, specifically at least in idiopathic disease. Sotatercept targets a very specific pathway, and I think it would be sort of premature to say that targeting that pathway could theoretically affect those who have lung disease PAH. And we see that same thing. Some people benefit from immunosuppression where other people don't in ILD-PH. Some people benefit from treating their lung disease versus treating their pulmonary vascular disease so differently. And so I think that is part of the challenge, is sort of harnessing the heterogeneity in this disease group and really then understanding how to apply it. And then I agree with Alejandro. I think the side effects or the adverse effects that we've seen specifically with bleeding, connective tissue disease patients is really challenging. And at least in my own practice, I have several patients where we're really struggling to manage that and maintain those patients on those drugs long term. And so that has to be thought about really carefully in really rigorous studies. We have another question here from Tris Wendell. I was diagnosed with ILD and PAH, group 1 and 3. It seems now that my lungs are clear with no ground glass opacities. My echo is normal. PFTs are still obstructive and restrictive. On Tyvaso, low prednisone. Is inhaled prednisone a better targeted path if this is inflammatory due to AIs? Okay. So I think the question here, there's maybe two questions. So one is, first of all, inhaled prednisone versus systemic prednisone. I think, again, that depends on the disease. I don't want to overgeneralize for the folks in the audience. I think that's a discussion really with your individual providers and clinicians to understand that. For some folks, inhaled steroids may make more sense versus systemic steroids. And then I think what we're seeing here, especially Tyvaso, is very interesting. Inhaled prostacyclins, as we discussed today, have a lot of different beneficial effects potentially, not only to the pulmonary vasculature, but also to the pulmonary parenchyma. Potentially, prostacyclins have the ability to counteract fibrosis, a lot of the anti-inflammatory properties. I think we're still waiting to see a lot of the results of these trials. We're anticipating positive things, but the mechanism still we're going to need to hear a lot more about. So I think that it sounds like this is on the right path. But again, this sort of brings out the heterogeneity and sort of treatment responses to folks.
Yeah, I agree. I think it will be important that you discuss with your pulmonologist or your physician about switching to an inhaled steroid. It will make sense, but there are so many details that we do not know here in the audience. So it's important that you discuss that. If for any reason that's not possible, you could also ask, because there are medications called steroid-sparing agents, medications that could also control inflammation without you staying on the steroid for too long, because as you mentioned, steroids have side effects, and you're probably having some of them. Yeah, talk to your doctor. I'm sure they will be open to answer your questions.
Okay, well, if there are no more questions, I think what we'll do is if I'll ask Roberto and Alejandro if you have any final take-home points before we close, and then we can turn this over to Matt to close us out.
Well, it's an exciting time for PH. We have inhaled treprostinil as a treatment option for PH-ILD, and we have sotatercept as a newer therapy for PAH. It's exciting. It's also exciting what PHA is doing, having this webinar and having the webinar in 2 languages, so a broader audience can benefit from these conversations. Thank you to the organizers for having us, and I hope all of you enjoy it.
I think that we have mentioned a lot during this webinar. It is really important to work in a collaborative fashion, patients association, physicians, and so on and so forth. And group 3, pulmonary hypertension, it is key to get all the patients associations together and to start understanding about this type of pulmonary hypertension, because it's a very frequent cause and it has a promising future ahead.
I couldn't agree more. I think that it's been such a pleasure to participate in this really unique, what I hope will not be the last type of collaboration today. It just sort of goes to show these are challenging diseases to treat. They take a lot of collaboration to treat, and they'll take a lot of collaboration to continue to recognize and continue to forward the research. So this has been wonderful, and thank you for including us.